Hello, today I'd like to talk about the surgical cricothyroidotomy, or as I'm going to refer to it for the rest of the video, the cric. Now this video is not intended to teach you how to perform a cric from the very first step until the last. Rather, it's just going to be 3 tricks that I have to set up my equipment that I've found help me to be successful. And I'd also like to talk about my specific technique for the lateral cut in the cric that I find to be safe, fast, and repeatable. So I'm going to move the camera forward and we'll start with the equipment. Alright, so my tips about equipment. These are all going to be in reference to actually prepping your equipment prior to using it. So my first one is going to be, I recommend that you tape your cric hook to your scalpel. Now, of course, this here is not the North American Rescue cric hook that comes with their kit. It's just a surgical retractor that I found floating around, but it's what I had, and ultimately what you have is what you use. So it demonstrates the point. Now, the North American Rescue cric hooks do come with that hard plastic cover, which I would recommend keeping on when you're not using them. That prevents you from getting hooked by your own, hook. Now, the thought process here is when you are performing your cric, you've got your non-dominant hand. I'm left-handed, so you've got your non-dominant hand stabilizing your patient's trachea, right? And so you make your cuts, and then you set your scalpel down, right? And now you're feeling around. It could be dark, say, and you're feeling around in the dark for your cric hook, which is somewhere, you're just not sure about exactly where. Now, that doesn't happen if your cric hook is taped to your scalpel. So you can make your cuts, and then you can just spin this around without losing contact with it, and you can just use your cric hook. So that's pretty elegant. Another technique that I have seen that works well is actually taking your cric hook and placing it between your ring and middle finger on your non-dominant hand. So that does work too. You then still do have your scalpel floating around, but it's better. All right, so tip number 2 is going to be to have your tube securing device prepped. All right, so in this case I'm using kind of this cotton rope that's often used for practicing sutures. And it does have these knots on the end, which is actually really good as an index point, kind of a tactile index point, so that you know when you've reached the end of your tube and your hand can't slip off of it. Now, IV tubing works really well too, but either way, I would recommend having it already tied on. In this case, I've used a clove hitch, and that is a really good way to secure it to your tube. Now, you'll notice too that one side is longer and one side shorter. I mentioned before that I'm left-handed, so in this case, the patient's head would be up here, body would be back here, and when I put this tube in, following the natural curvature, this shorter side is going to be toward me, and this longer side would then loop around the patient's neck and tie. So you've got kind of shorter tails that are of roughly equal length. It's certainly not necessary, but it does just kind of keep things a little bit cleaner. All right. And now tip number 3 is going to be simply have multiple tubes. And they should all be prepped the very same way, not like this. I just grabbed this tube real quick. And the thought process here is the limiting step in terms of how many crics you can perform is not the number of scalpels, because in the austere environment where you're not worried about sterility as much as you would be within a clean, sterile OR, the scalpel is not going to be your limiting factor. It's going to be the number of tubes, because you can use one scalpel for multiple crics, but you really can't use one tube for multiple crics. And this is probably a fairly uncommon requirement to have to do multiple crics at the very same time. But I suppose I could see it being plausible if you're dealing with inhalation burns, for example, where you could potentially have multiple people within the same area all have a very similar MOI and all require crics. So that's something that I would recommend. Now, of course, in any case, I would recommend carrying multiple scalpels on you. Okay, this is just specifically in your pouch that you have easily to hand. I would recommend carrying just one scalpel, multiple tubes, and also make sure that they're all set up the very same way, so that you know that no matter what tube you grab, it's going to perform the very same way. And I suppose one other benefit to it is these tubes really, it's hard plastic here, but you've got very soft plastic in the cuff and in the bulb. And so if that punctures, then all of a sudden you've lost the ability of that tube to actually secure that airway. So this way you've got backups as well. All right, so we talked about prepping equipment, so now I'd like to talk about technique. So here's a model that I made of a human trachea using jeans, 2x4, and bilge pump tubing there. So hopefully it works well. I've tried it out a couple times already, so it's already got some cuts in it. But we're just going to use this middle section here. And now to orient you, being as how I'm left-handed, I'm going to be on the patient's left, okay? So patient's head is going to be up here, and patient's feet are going to be down here. All right? So I'm going to start by finding my landmarks. I'm just going to trace up from the bottom, find that cricoid cartilage, thyroid cartilage right between them, cricothyroid membrane, okay? I'm going to stabilize that trachea really well, and then I'm going to make that long vertical incision. And I'm using the pencil technique and keeping my hand on the patient so that if he gets up really quick, he doesn't stab himself in the neck, okay? If he gets up, my hand moves with him. Does that make sense? All right, and now I'm gonna make my vertical incision. These jeans here are pretty tough, so. Now the tubing size I chose to approximate the size of a male human trachea, so it should be pretty good. Now I made my vertical incision, so I'm gonna feel to make sure that I'm still on target here, right? So I feel, and now what I'm gonna do is no slashing from my horizontal cuts. This isn't Fruit Ninja, all right? It's strictly gonna be a poke, all right? So the tip of my blade is gonna be midline on the trachea. I'm going to have my my scalpel canted at 45 to 30 degrees, okay? So canted, if this is straight, canted like that. All right, I'm gonna repalpate my landmarks, and I'm, simply going to poke, turn it around, same 45 to 30 degree angle, and poke. And I'm just going straight down. I'm not doing any slashing, okay? And now, just like we talked about before, with my cric hook already attached to my scalpel, I close up my blade, turn this around, stick my cric hook in sideways, turn it, and pull. And now I've got that nice hole there to insert the tube into. All right. All right, so I went ahead and turned the model so that now we're looking down the trachea in kind of a cross-sectional view. Okay, so again, trachea, I've pulled back the the jean skin, and you still have your 2x4 down here, all anatomically correct, of course. Now this is a 3/4 inch tube, which should equate to a human trachea, more or less. All right, and so I'd like to kind of compare and contrast the poke technique versus what I see a lot, which is the flicking technique or the slashing technique. Okay, so we're going to start with the slashing technique. Imagine you've already made your vertical incisions, and I pre-cut here, so I'm just going to use this one. So slashing technique, so you come in midline, right, and then you just, I'm going to hold this so it doesn't get away from me, and then you flick, and you turn this around, and you flick, and just like that, with perfect technique and not minimal depth, but just moderate depth, you've hemi-transected your trachea, right? It's already halfway cut through. And now, if you imagine that you've really got nerves going, right? So you're jittery, and you really send that scalpel, right? And then you do your flick, and you turn it around, and you really send that scalpel because you've got nerves going, and you flick. I think I might be stuck in the wood. And you flick, and look at that. That's your trachea. It's not happy. It just got transected. Plus, think of all of the damage to the surrounding tissues. So you've also cut the whole front side of your esophagus. You've cut all of the surrounding tissue to the left and right, okay? Just because you did that same technique, went a little bit too deep, and you did your flick, okay? And that's not good, to say the least. Versus if you do the popping technique here. Now I've kind of cut through where I had pre-cut before, so we're gonna have to just make a new cut. So remember, scalpel at 45 degrees, tip of the blade is midline or just past midline is a little bit safer. And then you're just going to pop through. You're going to turn your blade, again 45 degrees, and you're just going to pop through. Then you're going to close your blade up. And I'm just going to pull this so that we can see. Where before the trachea was hemi-transected, pretty inappropriate. This is a more appropriately sized hole for a cric, okay? And even that's a little bit big. This plastic is, I think it tore a little bit. So, but anyway, and now just to be fair, just like we did with the swishing, flicking technique, where you do any kind of lateral motion with the tip of your blade, let's imagine that you're doing the pop technique, but you're nervous, all right? You're jittery. So you really sink your scalpel when you pop in. Actually, let me use a fresh piece of plastic. So I'm moving down one ring here. So we're at 45 degrees. We pop through and we really sink that blade, all right? And then we come up. We're at 45 degrees. Whoops. And then we really sink that blade. Even with that, we still, yes, we've definitely pierced through the back of the trachea. We've hit the esophagus, right? But instead of having slash marks, I don't know if you would be able to see on the wood, we've got slash marks from the flicking technique. We've got two little kind of prick holes here, just little pin pricks in the esophagus. And what we do not have is a transected trachea. Rather, we have a bit of a larger than normal hole in the trachea here, but it still maintains its integrity due to uncompromised sections kind of around here and around here, okay? And then you got to think too, what you're not seeing is a whole bunch of damaged tissue surrounding it, okay? So where with the flicking technique, you basically wiped out whatever tissue was over here and over here. Here, you haven't, okay? So this tissue here is fine, this tissue here is undamaged, okay? So hopefully that kind of makes sense. I hope that this video demonstrating tips and techniques having to do with surgical cricothyroidotomies was helpful and that you learned something. If you have any questions, please feel free to reach out. Take care.